This video will cover the Class 1 drugs of abuse, and primarily the opioids, such as heroin and morphine, and the cannabinoids, such as THC. As a reminder, the Class 1 drugs of abuse activate G protein coupled receptors in the ventral tegmental area, or VTA. This activation causes GABA disinhibition, which results in the activation of mesolimbic dopamine neurons and the increased release of dopamine in the nucleus accumbens. Therefore, all drugs in this class activate G protein coupled receptors, and as I walk through each substance and its mechanism, I will identify the specific GPCR involved. Drugs in the opioid class, including the prototype opioid agonist morphine, produce reward and euphoria by activating mu-opioid receptors in the mesolimbic dopamine pathway. Specifically, these drugs activate mu-opioid receptors in the ventral tegmental area. Though I will talk about morphine and heroin as the prototypical opioid drugs of abuse, all opioid strong agonists produce tolerance and dependence, and most, if not all, strong opioid agonists also have the ability to cause addiction. This includes other opioid agonists like fentanyl, methadone, buprenorphine, hydrocodone, oxycodone, etc. It is interesting to note that although heroin or diacetylmorphine is typically associated with opioid abuse, it was actually initially synthesized and marketed as an opioid agonist for cough suppression, as shown in the graphic on the left from Bayer Pharmaceuticals in the 1940s. Due to its structure, heroin is much more rapidly transported to the brain upon IV administration and therefore produces a very rapid onset euphoric feeling as well as a very rapid termination of its effects. And therefore, the kinetics of heroin are faster on, faster off than is morphine. We'll talk a little bit more about the kinetics on a subsequent slide. Again, all opioids, at least all strong opioid agonists, produce euphoria by activating mu-opioid receptors in the VTA. Their other short-term effects or acute effects include analgesia, sedation, constipation, and respiratory depression, as we've looked at previously. All strong opioid agonists produce dependence, and upon abrupt discontinuation or administration of an antagonist like naloxone, there is a moderate to severe withdrawal syndrome that includes symptoms like increased pain sensitivity, dysphoria, insomnia, nausea, vomiting, and diarrhea, hyperventilation, as well as increased secretions like lacrimation and rhinorrhea, and pupil dilation. Many of these symptoms are actually direct opposite of the acute effects of the opioid drugs. And most of them are associated with increased autonomic nervous system activity. The graphic on the screen here describes the DSM-5 diagnostic criteria for opioid use disorder. Specifically, in individuals where opioids are taken in larger amounts or duration, a persistent desire to cut down or control use that is unsuccessful, spending a great deal of time obtaining, using, or recovering from the effects of opioids, craving opioids, etc. An individual who has several of these criteria is considered to have either mild, moderate, or severe opioid use disorder, depending on how many symptoms are present. Note that it is possible for patients to meet the criteria for numbers 10 and 11, tolerance and withdrawal, without being addicted to the opioid. And that is why there need to be at least 2 or 3 symptoms for the individual to be diagnosed with opioid use disorder. In general, when treating substance use disorders, there are 3 aspects of substance use that are treated with therapeutics. The first is overdose or intoxication. In many cases, there is an antidote or reversal agent that can reduce death in overdose. The next area of substance use disorder that might involve treatment is the withdrawal syndrome, which can be very problematic and in certain cases deadly, depending on the substance. Or the substance use disorder itself may be treated with something like a substitution therapeutic. The premise of substitution therapy is that substituting a less harmful or problematic agent for the one that is being abused is a better course of action than allowing continued use of the problematic substance. This is epitomized by the substitution of methadone or buprenorphine for an opioid like heroin. The main reason for substituting either methadone or buprenorphine is the fact that methadone and buprenorphine have much longer kinetics than does heroin. Both methadone and buprenorphine have a longer half-life than does heroin, and the intention of this longer half-life is that you reduce the number of times the individual feels high or euphoric, but you also prevent the individual from feeling sick or withdrawn by keeping drug levels within a tight normal window. This is opposed to heroin, which has very rapid on and offset kinetics, and therefore individuals go from feeling sick to feeling high in a matter of just a few hours. On the other hand, methadone can be taken just once a day in most cases, and drug levels can be maintained in a normal range for that 24-hour period of time. One important thing to note with substitution therapeutics is that many times they are associated with the same adverse effects and chronic use problems as the original substance of abuse. So, for instance, methadone and buprenorphine can both still produce tolerance and dependence. Both are still addictive, and both are associated with the acute adverse effects that heroin and morphine are, like respiratory depression and constipation. So while this is not a perfect substitution, again, substituting something that is less harmful for the more harmful substance that is being abused is a common treatment modality. In the case of opioid use disorder, there is one agent that is approved for reversal of overdose or intoxication, and that is naloxone. Naloxone can be administered either by autoinjector, which is Evzio, or it can be administered as a nasal spray, which is also called Narcan. Naloxone is an opioid antagonist that immediately outcompetes for binding to the mu opioid receptor and causes immediate reversal of those problematic acute effects of opioid agonists like respiratory depression. There are several agents that may also be used during the withdrawal phase to reduce the signs and symptoms of opioid withdrawal. Two of those agents, clonidine and lofexidine, are alpha-2 adrenergic agonists, which decrease sympathetic outflow centrally by activating presynaptic alpha-2 autoreceptors in the central nervous system. These reduce many of the signs and symptoms of opioid withdrawal, given that they are primarily autonomic mediated. Methadone and buprenorphine as substitution therapies can delay the onset of withdrawal because they substitute for the substance that was being abused, whether that was heroin or fentanyl or morphine or another opioid. The next set of class 1 agents are the cannabinoids, with the primary cannabinoid being delta 9 tetrahydrocannabinol or THC. THC and THC-like compounds come from the cannabis plant, and they are psychoactive. The cannabis plant does also contain other components like cannabidiol or CBD, which is non-psychoactive and is actually thought to have anti-inflammatory activity. The rewarding effects of THC are due to activation of cannabinoid 1 receptors in the VTA. The acute effects of THC include euphoria, cognitive deficits, increased hunger, and altered sensory perceptions. After chronic and continued use, there is a mild withdrawal syndrome upon abrupt discontinuation that includes irritability, restlessness, insomnia, and nausea. At this time, cannabis use disorder is just beginning to be studied and understood. And therefore, there is not a really well understood pathway or diagnostic criterion like there is for opioid use disorder, nor are there therapeutics that would be utilized in individuals with suspected cannabis use disorder. However, what I wanted to highlight here is that there are actually several cannabinoid compounds that are used for therapeutic benefit in certain conditions. And that is because of the known effect or activity of THC to increase appetite, reduce nausea, and to reduce seizure burden by generally decreasing or dampening overactive neuronal activity. The first cannabinoid therapeutic is dronabinol or Marinol. Dronabinol is essentially synthetic THC, and it is indicated for appetite stimulation in AIDS wasting syndrome and for chemotherapy-induced emesis or vomiting. Another synthetic THC product, Nabilone or Cesamet, is also indicated for chemotherapy-induced vomiting. Recently, the cannabidiol or CBD therapeutic Epidiolex was approved for seizures associated with two different epilepsy syndromes, Lennox-Gastaut and Dravet syndrome, in children 2 years of age and older. The graph on the right demonstrates the efficacy of Epidiolex compared with other standard epilepsy treatments. As you can see, the effects of Epidiolex in reducing drop seizures, which are also called tonic-clonic seizures, in individuals with these epileptic syndromes is comparable to other standard epilepsy therapies like lamotrigine and topiramate. The main advantage of Epidiolex is that it is associated with significantly fewer side effects than are some of these other epilepsy therapies. Epidiolex is approved in the US for this purpose. As I mentioned in the multiple sclerosis lecture, there is also a THC CBD combination product that is a mouth spray formulation called Sativex that is improved in Canada for muscle spasticity associated with multiple sclerosis. These cannabinoid therapies are just beginning to be studied, and I have a feeling that many more cannabinoid therapies will be coming down the pipeline relatively soon. Other drugs of abuse in the class 1 group, and again, as a reminder, these are drugs that activate G protein coupled receptors in the VTA, include GHB or gamma hydroxybutyrate, also known as the date rape drug, LSD, mescaline, and psilocybin. GHB is a natural metabolite of the neurotransmitter GABA. It was first introduced in the 1960s as a general anesthetic, and there is a GHB product that is FDA approved for the treatment of narcolepsy called Xyrem. Its acute effects include euphoria, sedation, and amnesia, and this is one of the reasons it became popular as a date rape drug throughout the 70s and 80s. The hallucinogens include LSD, mescaline, and psilocybin. Again, these are drugs that are typically thought of as non-addictive drugs of abuse, because even though they are abused or used for alternate or inappropriate purposes, they are typically considered non-addictive because they do not stimulate dopamine release in the nucleus accumbens. LSD and mescaline and psilocybin are all hallucinogens due to their ability to alter states of consciousness. The main acute effects they produce include perceptual symptoms, somatic symptoms, as well as psychosis-like manifestations. They do cause tolerance and dependence, but as I stated earlier, are not typically thought to cause addiction. The mechanism of action of these hallucinogens is to stimulate serotonin 5-HT2A receptors, resulting in the increase of glutamate release in the cortex. This increased glutamate release in the cortex is what leads to the perceptual disturbances and symptoms associated with their use. LSD in particular is an ergot alkaloid, similar to the ergot alkaloids used in migraine therapy, with a very rapid onset of about 30 minutes and a long duration of action, about 6 to 12 hours. It is not neurotoxic, but as an ergot alkaloid, it can induce abortion due to its ability to stimulate uterine contractions. Now is a good time to review the use of various treatments for opioid use disorder. Specifically, consider the use of naloxone in the treatment of opioid overdose or intoxication. Why is it effective for this purpose? And how should it be administered? You can take a photo of the QR code for a quick video with some additional information on this topic.